Okay, I believe that we're working now. Thank you everyone for joining. This is the February 8th webinar of Connecticut's Sustanet Healthcare Workforce Task Force. I am Ellen Andrews, co-chair of the committee with Dr. David Henderson. And David, I don't know if you want to say a few words.
Actually, again, just thank you all for agreeing to meet with us. And just a quick question about how we want to conduct this. Marcia, do you have any, do you want to go through the PowerPoint and then have a discussion? Would it be okay for us to ask questions during the course of the PowerPoint? How do you want to do this?
Actually, as a host, I'm going to defer to Ellen to see if she had a preconceived way to go through today's session.
I think just because we have so many presenters, I thought we would wait until the end. People can type questions in, so you don't have to remember them. But I think we'll wait until the end to take questions, if that makes sense.
That works.
Okay. And I have a question already on that subject from Kristen, and she does not have a way to ask questions by voice, but she can type them in because she's already done it twice. So let's go through that part. This webinar includes representatives of critical healthcare provider and professional organizations in Connecticut. A little housekeeping: if you are listening on the phone, remember to input the audio pin that should be visible on your screen. If you want to be able to talk and ask questions, you can raise your hand or you can type them into the question pane, and I will read them to the presenters at the end. We will be keeping everyone on mute, the participants on mute, until the speakers are finished with their presentations, and then we'll have questions. The slides and a video of this webinar will be posted soon online. We're going to start with Marcia Proto. She is the regional sales manager for the National League for Nursing. She was the executive director of the Connecticut League for Nursing from 2004 to 2007. She has worked in a number of places, including the Connecticut Hospital Association. She has a master's in education and a certificate of advanced study in personnel from Springfield College and a bachelor's from Providence College in Rhode Island. Marcia, we can start.
Sure. Thank you so much, Ellen, and it's a pleasure to be part of such a dynamic discussion, especially at such a turning point as healthcare reform is going to be coming down and really impacting us in some way, shape, or form. You'll actually see on my opening slide that I'm a co-executive director for the Connecticut League for Nursing. I am back very part-time in that role, working with the deans and directors from around the state, representing all schools from doctoral on down to LPN, as well as my role with the National League for Nursing, which is to work with nursing schools and healthcare facilities throughout the states of Connecticut and New York. So I have a wonderful opportunity to really listen to what's going on in the industry and also try to get a bit of a handle on what workforce issues are facing our profession of nursing in specific, but how it will impact the provision of care in general. So just wanted to set the tone based in a big picture way. As many of you may know, nursing is the largest profession within healthcare. And not only when you think of hospitals being the largest clinical provider within those walls, but clearly as it permeates down to community health, you have your advanced practice nurses being the point people for care, as well as everything from school nurses to case managers with insurance, to surgery centers, to specialty clinics and oncology, etc. So nurses are really permeating our entire healthcare system clinically, but also complementing it on the business end. And fortunately or unfortunately, nursing has not been well represented in the entire discussion of reform. Fortunate to say, Dr. Beverly Malone, who is the president of the National League for Nursing, used to be the highest ranking nurse under the Bill Clinton administration, and Dr. Malone was brought in about 2 years ago when they were talking about health care reform, and then brought in again by President Obama when he had the focus groups right in the outset of his administration. So we do have a seat at the table, but I don't know what the perspective is as that moves forward. One of the very important issues that I think sets the tone for this entire conversation regarding nursing is a nurse is not a nurse is not a nurse. The state of Connecticut, as you all know, just did away with the state LPN program. And that program provided about 450 LPNs every 15 to 18 months. And that would really staff most of our long-term care facilities, although some hospitals do hire LPNs under different titles, whether it be dialysis or some other of their subacute care. That is a huge number of LPNs that we will not have as a resource to care for our older adults in predominantly our long-term care settings. As you may or may not know, if a nurse goes to a 2-year associate degree program or a 4-year baccalaureate degree program, they actually sit for the same nursing board. So there's no differential in practice or no differential in pay. The only caveat with a baccalaureate degree is if somebody's working in an organization, the administration, if they're to promote and hire or look for supervisors or managers, they do require a baccalaureate degree. Those RNs, who are your baccalaureate prepared or associate degree prepared, cannot do what an advanced practice nurse can do with a clinical specialty, or an advanced practice nurse who has a focus in education. And he or she who has that designation would teach, whether they teach in a hospital as a clinical educator or even in work as an educator within public health. The big role that we need these master's prepared nurses in education are faculty roles. And you'll see in just a moment, Ellen, if you go to the next slide, we don't have enough nurses to fill all these roles. Large part being that in Connecticut, we rank 49th out of 50 states in producing nurses. We lag behind national trends by other states in supporting nursing education. Back in 2005, the Connecticut League for Nursing and all of the deans and directors for the state of Connecticut published a report highlighting what the potential gap is going to be of nurses produced versus how many we need. And just a few years ago, I had heard from someone in Department of Higher Education for the state of Connecticut is, well, we produce about 12,000 nurses. We have about 12,000 vacancies, so we're flush. But the important caveat that that individual wasn't quite up to speed is that a nurse is not a nurse that is not a nurse. So we aren't producing the right type of nurse for the positions that are available. And then lastly, we have a big hurdle in Connecticut. Besides having a faculty that's very old in age and not very diverse, who will be retiring in the next 3 to 5 years, we also have numerous individuals, going along to the last item, that want to enter nursing school that are actually academically qualified, and many of them go to other states for service, and we can't accept them because we don't have enough slots. Ellen, if you'd like to go forth again. Next slide. And this is just a snapshot back in 2004, but the data was published in 2005, looking on a national basis where our aging population of nursing is. And for those who have color screen, it's in the teal with the little arrows pointing at each other. And that big bubble on top, you'll notice, is moving to the right, which indicates that our nurses are getting very old. If you could go another slide, please, Ellen. The hard part about creating nurses, and if you look at this slide, this is actually part of the Guide to Nursing Education, which the Connecticut League publishes every 2 years, listing all of the programs, all of the careers, resources, and employers in the state of Connecticut. And this is a very complex slide. It goes to the fact that getting into nursing school, the different levels of nursing, is extremely complex. I actually have a nice full-page slide if people would like to look at it, but the real message is we know what kind of nurses we need to provide care. We know that we need nursing faculty, which are master's and baccalaureate prepared. Unless we start creating a pipeline and moving these associate and bachelor's degree nurses to master's programs, which we know takes 3 to 5 years because life gets in the way, we truly are not going to have enough faculty to teach the next generation. Ellen, could you please go next slide? And what I had put together and what we actually shared before I left the Connecticut League back in 2007 is to give you an idea of what barriers that nursing faces in today's market. And if you look over in the far left, it looks at credentials to teach and what type of annual compensation a teacher will get. So to produce associate degree students, we actually need nurses that have a master's degree in nursing education or a bachelor's degree who are going to be starting their formal education for their master's. And then if you look a little taller, I'm going from the bottom up, if you're going to be teaching at a baccalaureate program or a master's program or a doctoral program, those nursing educators need to have a PhD or a master's in nursing education moving towards a PhD. And then if you keep going to the third column and you look at what other opportunities are available to these master's and doctoral or baccalaureate prepared nurses in the specific industry as well as the correlating salary, you'll notice the top of each group is nurse educators, and clearly the compensation is 1/3 to 1/2 less of what they can make in the job market today. So you have to look and say, why would someone want to be a faculty? Well, they have a passion and desire to continue producing qualified nurses, and the whole bottom line is patient care, quality patient care. So when we discuss reform, we truly must focus on nursing and how we're going to fill the bill. Thanks, Ellen.
Great, thank you. Next, we're going to hear from Matt Katz. Matt is, since 2006, has been the Executive Vice President, Executive Director of the Connecticut State Medical Society, the state's largest physician organization. It was founded in 1792. Wow. Matt is the former Director of Private Payer Advocacy and Director of the Practice Management Center at the American Medical Association. Prior to his arrival at the AMA in 1998, Matt was a financial analyst in the Department of Managed Care at Northwestern Memorial Hospital. Before that, he was a policy analyst in the Division of Physician Payment Systems at the American Academy of Pediatrics. He also, and I'm going to out you here, Matt, he worked for Medica Health Plans of Alina Health System and United Health Group. He's a native of Minnesota, and he received a fellowship and earned his Master of Science in Health Services Research and Policy from the Institute for Health Services Research and Policy at the University of Minnesota. Thank you, Matt.
Thank you, Ellen, for reading all that. And yes, I did work for health plans at one time. So
yes.
I also worked for a hospital, so I feel that I have a full-rounded education from the perspective of the healthcare arena. I wanted to thank everyone today for allowing me the opportunity to speak, and thank you, Ellen, for coordinating this. If you want to go to the first slide, what we're going to be talking today about is the workforce study that the Medical Society did back in 2008. We put the survey out in April through July of 2008 with the support of the Universal Healthcare Foundation, a not-for-profit in Connecticut. We sent the workforce survey to approximately 4,000 practicing physicians in Connecticut, representing 17 unique specialties. Those specialties are identified here. We did not include some specialties simply because of their lack of direct contact with patients, as well as some other factors associated with how they do business in Connecticut. We also eliminated some academic medicine and research physicians within that list of physicians that we sent it to. It is important to recognize, and it's not on these slides, but to recognize that Connecticut has one of the top three, and this is not a good top three oldest physician populations in the country. The average age of physicians in Connecticut are 53 years old. So in looking at the nursing slides and where they're creeping up, physicians are literally creeping down the back end of that hump, and we have many physicians, I like to say thanks to the market, are still practicing that wouldn't have been practicing if the markets hadn't dramatically changed the way they did it a year and a half ago. We do have a very aged population. So over 1,075 physicians responded to the survey, close to a 27% response rate. And the demographics are in front of you here. I'm sorry they're hard to read on the slide, but just to give you some understanding, we have a good representation of self-employed physicians. This study shows 52%, but in general, 60% of physicians in Connecticut are solo, and more than 80% are in groups of 4 or less. We are very much a small practice environment in Connecticut. The Marcus Welby, if you will, house call approach to medicine, which the physicians of Connecticut hold near and dear to their hearts. Next slide, please. So we looked at 5 general areas in the study in 2008. We looked at physician satisfaction with their careers, recruitment and retention, some liability issues and exposure to high-risk patients, factors affecting access to care, as well as business aspects of medicine, particularly payer mix, burden of ER, and technical integration. Next slide, please. This is important. This focuses on physician satisfaction. This is a 7-point scale, so, excuse me, a 5-point scale. So very satisfied is 5. If you see, the majority of physicians, with respect to their own career, were relatively satisfied, with neurosurgeons, general surgeons, OBGYNs, family physicians, internists, and urologists being least satisfied. And some of those, there's reasons for it that I'll show you in a minute. Next slide, please. Those specialties that exhibited the lowest level of satisfaction were also least likely to recommend practicing in Connecticut. Now, I know that doesn't strike you as odd, but if you notice, from a satisfied perspective or likely perspective, they all seemed relatively satisfied, but when it came to actually practicing in Connecticut, they were less so. This is important because when physicians look to go to places to practice, they often ask their peers, they ask those they went to medical school or did residency training with, or they ask those that they'll be coming into the market what their perceptions are. So this does not bode well for certain specialties when it comes to people potentially coming in. Next slide, please. This is also important to look at. Older physicians, those that have been practicing longer, were more likely to be satisfied with their career than younger physicians, while physicians in smaller practices were less satisfied than larger groups, recognizing, again, the majority of physicians in Connecticut are in small groups. Now, thankfully, the majority of physicians in Connecticut are older, but we're having a very difficult time attracting younger physicians, and we'll get to that in a minute. Next slide, please. Overall, 20% of physicians were contemplating a career change, with neurosurgeons, general surgeons, orthopedic surgeons being the most likely to actually contemplate a career change. ER physicians, dermatologists, and psychiatrists being the least likely. Again, it shows you the differences of opinion between physician specialties, but some having significant concerns and issues associated with the practice environment in Connecticut. Next slide, please. Once again, neurosurgeons, along with urologists and dermatologists, found that recruiting new physicians was most difficult. If you notice, when you have someone retiring, you would like to have someone fill their spot. For some of these specialties, it's taking a very long time. Next slide, please. This is what we asked about liability and concerns regarding liability. They were most strongly felt by those neurosurgeons, general surgeons, orthopedists, and urologists, those same specialties that indicated it was hard to recruit and they were less satisfied with their environment and their own personal satisfaction with their careers in Connecticut. Next slide, please. Now, this is important for access to care in Connecticut. These same specialties were most likely to reduce their exposure to high-risk patients, as well as most likely to reduce performing high-risk services. Next slide, please. Sorry, did it switch to the next slide? Yep, okay, I'm sorry.
Sorry.
Um,
Too far.
Again, this next slide focuses on how long it takes to retain referrals. This is problematic for pediatricians and ER physicians, as you see how long it takes them or the problems they're having associated with referrals. As you know, most people come in and access the system in Connecticut either through the ERs or their primary care physicians. It's those physicians that are having the hardest time finding referrals for their patients to get necessary care. So it's not just a primary care access issue, it's also a specialist issue. Next slide, please. So what do we have to do? We have to look at controlling costs, making health insurance affordable, covering the uninsured, focusing on chronic illness and prevention, reducing administrative burdens, improving the system, and regulating insurance practices. All easy things to do, right? Next slide, please. I just wanted to say in summary, and the problem we have here in Connecticut is that 20% of our doctors are contemplating a career change. 10% are planning actually moving out of state, and we've seen a dramatic increase of doctors moving out of state in the last 2 years. 90% of physicians in Litchfield, New London, and Wyndham, our most rural counties, found recruiting to be very or somewhat difficult. 50% of all physicians have increased their work hours in Connecticut over the last 3 years. That is inconsistent with the rest of the country. Less than 50% of the payments come from commercial insurers today in Connecticut because Medicare and Medicaid take up such a dramatic portion of the payments within a physician's practice. So it's not just the insurer issue that we have to deal with. 40% of physicians are providing fewer risk. 34% say it's because of liability concerns. 90% of ER docs, 70% of pediatricians can't find a referral or a consult. And new patient waits last on average 17 days to see a primary care physician or a specialist. And physicians do support expanding the safety net, ensuring that in fact there is an ability and way for patients to access care. Whether it's through a single payer system or some other system, they believe that additional care options are necessary. Next slide, please. I just want to highlight that in addition to this study, CSMS did a disparities healthcare study that was completed last fall. It showed that we have an issue tied to disparities in healthcare and accessing physicians of like backgrounds. We have to look at the types of physicians as well as the geographical locations where those physicians are. We also are working and will be publishing in 2 months our primary care workforce study that was a follow-up to this study that highlighted some unfortunately additional problems that primary care physicians are experiencing within the marketplace. And then we did a practice management survey back in 2007. I believe that's the last slide.
Yep. Great. Thank you. Next we have Scott Selig he's Director of Clinical Quality at the Connecticut Community Health Center Association of Connecticut. He's providing leadership and administration for the clinically focused programs there. He directs development and implementation of quality improvement activities for all programs. He represents CHCACT at state, regional, and national meetings and makes presentations on behalf of the organization. He has a Master of Arts in Teaching and formerly served as a high school teacher, an adjunct professor, a director of several nonprofits, a manager in the Department of Medical Education at CCMC, a program manager for education at Yale New Haven Center for Emergency Preparedness and Disaster Response. A very interesting resume there, Scott. And you can start anytime.
Okay, great. Thank you for having me. And I'm being joined with Rashad Collins, who is our program manager for workforce development. Rashad started with us in December, so I'm not going to throw his feet to the fire yet. But I do want to talk a little bit about the bad news, but we also have some good news that we can share with you. So just so you get an overview of the community health center world, we staff approximately 2,100 clinical staff in our health centers throughout the state. We've got 14 community health centers in the state. They're in Danbury, Stanford, Waterbury, New Haven, Bridgeport, Willimantic, Hartford, in the New London counties, and Torrington as well. So they cover the whole state, rural and urban communities. And we currently have 22 clinical openings at those community health centers. And really what we have is a real workforce, deficiency. We are very lucky that the federal government's identified federally qualified community health centers as a great resource for healthcare disparities. But the problem, and so we've gotten great funds to help build that infrastructure. Construction in dental suites and medical suites are going on throughout the state at the community health centers. But the real issue is, how do we staff those dental and medical suites as we're building those facilities? So if you want to go to the next slide, we're very fortunate to, and there's a nice map of all the federally qualified community health centers. You can go to the next slide. So we are very lucky that we are now participating in a program that's called SEARCH, which is Student and Resident Experiences and Rotations in Community Health. We know that we need to recruit students in a number of different disciplines to want to work in primary care and then also want to work in the community health center world. And so what we're trying to do is partner with academic medical centers and teaching centers in different disciplines, and to get those students to get positive experiences in those settings, so then hopefully after they're done with their training, they'll work in those settings for their careers. Next slide, please. So the SEARCH program is, it enables, it's a unique program that enables the National Health Service scholars and other healthcare profession students and residents to work in interdisciplinary teams to care for the underserved in rural and urban settings. Again, that idea of interdisciplinary teams is a very interesting approach, because we all know in the professional world, in the medical world, we work in interdisciplinary teams. We do it in the medical world, we do it in the behavioral health and mental health world, and we do it in the dental world. But when we go to school, we don't necessarily go to school and do training with people from these interdisciplinary teams and these other disciplines. So we're really trying to emphasize this experience on a student level. So who can participate in this Connecticut SEARCH program? Well, students. There would be dental students, medical students, nurse practitioner, and physician assistant students. Residents, both medical residents and dental residents, and then the preceptors will be coming from and mentors will be coming from the federally qualified community health centers. Next slide. So what are we looking to do? We're looking to provide opportunities for students to partner with their classroom experience to get experiences in a healthcare setting, provide opportunities for the students and residents to train on multidisciplinary healthcare teams, nurture the development of culturally competent and community responsive primary and allied health providers, expand statewide partnerships to form a network of organizations to meet the diverse primary care needs of the underserved. So what's our program specifically going to do? We're going to provide 23 students with the ability to participate in 6-week summer internships at federally qualified community health centers. The students are going to get a $3,000 living stipend. We're going to have professional development workshops that we're going to provide for those students. They're going to get clinical experiences and have trained preceptors. We're actually developing a preceptor curriculum in partnership with the University of Connecticut School of Medicine. The preceptor curriculum is called Primary Care Curriculum for Advanced Mentors and Preceptors. And this curriculum is not only going to be developed here in Connecticut, but Dr. Bruce Gould, who's one of the PIs on that project, is going around to national conferences this fall and early winter, and he'll be presenting on that curriculum, hopefully as a national model, as a curriculum for preceptors and mentors in the primary care world. We'll have 16 SEARCH residents complete multidisciplinary rotation at the federally qualified community health centers, and we're one of 28 states that are participating in this program. Next slide. Okay, so you can see that we've got some action steps. We've got to recruit the students and the residents. It's a 3-year program. We've got to, again, work with our health centers to make sure that they're ready to receive these students. There are currently students that are, and residents that are working in community health center settings, but we want to make sure that that experience is a great experience and is going to encourage them to work in this field after they get out of school. So the idea that we're partnering this with this curriculum development, and that we're going to be piloting this curriculum for the preceptors and mentors, making sure that the preceptors and mentors have the time to nurture these students is a real vital, important step. Next slide. Our partners are University of Connecticut, AHEC, Dr. Lepowsky from the University of Connecticut School of Dental Medicine. We've got the 13, now it's 14 community health centers that are participating. And I just wanted to say that our academic partners are Quinnipiac University School of Physician Assistants. We've got Dr. Cindy Lord that's on our team. We've got Fairfield University School of Nursing. Dr. Phil Greiner is on our team. At University of Connecticut School of Medicine, we've got Dr. Bruce Gould. At University of Connecticut School of Nursing, we've got Dr. Sandy Bellini. At Yale School of Nursing, we've got Dr. Ivy Alexander. And then we also are pulling in the Yale School of Medicine and Yale School of for Physician Assistants as well. So, and then we've got the Yale School of Dentistry. So we really are looking to create this network of academic institutions that provide clinical training and provide this and have this network not only be part of this search program, but go beyond that and have this be an opportunity for those schools to share best practices and a lot of other information, because we feel that that's an important thing. And we're also partnering with the Department of Health, sits on with us on this committee, as does the Connecticut Rural Health Department as well, to make sure that we are focusing on the community health centers that serve our rural populations. So that's the project. So that's the good news, that hopefully after this project and other projects like it across the country, we'll be attracting students to work in community health centers. Can we guarantee that they're all going to work here in Connecticut? Not necessarily, but we can hopefully start this process. And again, I encourage people to work for community health centers in these for these underserved populations in rural and urban settings. Any questions?
I think we'll do questions at the end.
Okay. Okay, great.
Next, we have Dr. John Davis. He's the president-elect of the Connecticut State Dental Association. Dr. Davis graduated from Tufts University School of Dental Medicine in 1976. In that same year, he opened his private general dentistry practice in Fairfield, where he continues to practice today. Dr. Davis.
Hello, everybody. Thanks for inviting the Connecticut State Dental Association and myself to share some good dental news with everybody today. It sounds like we're on the better side of nursing and physicians. Could I have the next slide, please?
Sure.
What my slides are going to show is how, and we deal mostly with access to care as far as workforce issues go, and the access to care for dentistry and children in particular on Husky A has improved from 2007 to 2010. As you can see on this slide, the ratio of practicing dentists to population in Connecticut is the second highest in the nation, and that Connecticut ranks first in the nation in adult visits to a dental clinic or a dentist within the past year. The report goes on to state that less than half the children enrolled in Husky, though, between the ages of 3 and 19, have received any dental care in a one-year period. Can I have the next slide? And, few children were seen for dental care because only about 150 dentists participated in Husky A up until 2009. And the reasons for low participation is just like same problems physicians have. Among the dentists, the major problems were low reimbursement rates and administrative barriers within the Medicaid system. Could I have the next one, please? In 2006, the Connecticut State Dental Association, along with several other organizations, formed the Oral Health Strategy Group, and they were to advocate for increased reimbursement rates and improved administrative procedures in order to recruit additional dentists into the dental Medicaid program. And as the legislature was preparing to raise the reimbursement rates, the Connecticut State Dental Association publicly pledged to increase dentist participation in the Medicare program to 400 providers. Okay, the next slide, please. And as you can see, in 2008, there was a $20 million carve-out for dental Medicaid fees. This was brought about by the settlement of a 7-year lawsuit. This, along with decreased administrative obstacles and a single payer, effectively eliminated the barriers preventing dentists from participating in the Husky program. Okay, the next slide. And because of improvements in the program, today there are over 1,000 dentists who participate, and there's been a 60% increase in children's visits, and now any child enrolled in the Husky program who wants care can receive it. Okay, the next one. More children are being seen in private dental offices and school-based clinics than ever before, and as a result, there's only 10% of the 1,781 patients seen at the 2009 Connecticut Mission of Mercy. This is a 2-day free dental clinic sponsored by the Connecticut State Dental Association and the Connecticut Foundation for Dental Outreach. The number of children seen was very, very low, and we can go on and say that the wait times for children for dental appointments within the Husky system now closely mimics that of private paying patients. So they can get emergency appointments within 24 hours and regular appointments for routine visits within 18 days. Okay, the next slide, please. The Dental Association has made a lot of progress, and now we're turning more towards recruiting specialty providers, such as the oral surgeons, orthodontists, periodontists, and endodontists. The general dentists have stepped up to the plate very well. Now we just need the specialists to come in and help the rest of us out. The CSDA will continue to advocate for increased funding for Connecticut school-based clinics, and here again, this is probably where it could be the most efficient model for delivering dental care to children. Okay, the next slide. While more children are enrolled in Husky and are receiving dental care than ever before, the Connecticut Mission of Mercy and other Connecticut State Dental Association pro bono clinics have glaringly illustrated the serious need for improved access to care for the adult, elderly, and special needs patients. And the CSDA will continue to work with the governor and legislature to come up with innovative solutions to the adult access problem, particularly for the adults who do not qualify for state-assisted programs and cannot afford to pay out of pocket for dental care. And really just to summarize, at this time the dental workforce in Connecticut is adequate. What is needed is improved funding for adult dental Medicaid. Fees to treat children are fine, but the adult fees are 52% of the children's fees, which is inadequate to entice providers to treat adults. I think if adult fees were increased to reasonable levels, the need for missions of mercy would be greatly decreased and adult dental health would be greatly increased. And that's pretty much all I have to say. Thanks.
That's great. We have a question from David Gassior. I think this is probably for you, Marcia. Could this nursing shortage be caused by employers setting wages below competitive levels? Also, I understand there is a large transaction cost theory for nursing, since most nurses have to travel long distances to get to work. Could these both combine to act in creating this shortage?
No, actually the shortage is due to the capacity issue of nursing schools. Due to the shortage of masters and doctoral prepared nurses who want to teach, we can't expand our enrollments. We're actually extremely fortunate in Connecticut that primarily for student nurses, they do their clinical rotations in hospitals and long-term care facilities. We have over 250 long-term care facilities as well as 31 hospitals in the state, so the travel distance is very, very short. Going along with the whole physician issues, we are very fortunate for nursing that the economy did tank because many of the nurses who were planning to retire did not. And there were some federal studies done in 205, 206 that forecast that Connecticut by 2020 was going to have a 20,000 nurse shortage. I think due to this delay and some creative staffing and 36-hour, 3-day shifts that facilities have been doing, we've been able to mitigate the initial impact, but once these nurses start to retire, there's no way that we have a pipeline to replenish the bedside nurse as well as the other nurses.
Okay. Let's see. I think that I don't have any hands raised. I don't have any questions. Kristen has a question. Kristen, are you on?
Yes.
Go ahead.
Yes. Okay. I was just wondering if the dental hygienist is still an issue, and whether, in your opinion, there's still a shortage using dental hygienists, or if they've made gains that way, utilizing them for children's dental health.
You're probably referring to the advanced dental hygiene practitioner?
Yes.
This is a bill that gets introduced. It's been introduced probably the past 3 years in the legislature. And at this point in time, there probably isn't any need. We've made great strides in recruiting dentists to take up the slack while treating the Medicaid Husky A kids. And as I said, just about any kid who wants to be treated now can be treated.
That's great.
In a dental office or in a school-based setting. And that's, our next real focus is going to emphasize the school-based setting because, most of the children are poor. Their parents are working parents who can't take time off for work, can't bring them to an appointment. But if we can get a clinic set up in a school and they can come right out of class and be seen, it's probably the best way to do it.
Great. We have
okay, thank you.
We have a question for Matt from John Davis. Panelists are asking each other questions. This is great. Why is Connecticut not a good place for MDs to practice?
Well, I wouldn't say it's not a good place for MDs to practice. However, there's a lot of factors that the study found impacting or influencing physicians' decisions to practice or to leave the state, including issues of high administrative burden tied into managed care plans, the high liability rates. We have actually one of the highest in the nation for many specialties and subspecialties in practice and internal medicine in the country. In addition, we tend to have a higher cost of living in general than other states, so it costs more in Connecticut, and physicians get paid relatively the same or less compared to some of their colleagues in other parts of the country. We have not done a good job with our academic institutions here keeping those medical students and residents in Connecticut. Though UConn has a greater percentage of their graduates, medical students and residents staying in Connecticut, Yale has very few, and we don't get many young physicians to Connecticut anymore. In fact, we believe we have more people leaving the state than, well, we know we have more physicians leaving the state than coming to the state. We have a large number of licensed physicians in Connecticut. That is because we have 2 academic institutions that people get licensed at when they come here for their training and maintain it. But we do not have that many that actually still practice in Connecticut. And I think we are unique in many ways tied into the academic environment that's within Connecticut, the administrative burdens tied to high proportions or propensity of managed care and concentration, some of which has happened even more fully in the last few months, as well as the issue of liability, where most states have seen a reduction in recent years for physicians and liability expense. Connecticut has actually seen an increase or maintenance in those high liability rates. But I still think, and we still believe at the Medical Society, it is a wonderful place to practice medicine, especially for physicians that want to practice in solo or small practice environments, still see their patients, still be able to make house calls and treat the patients the way they believe they need to be treated.
Okay, we have another question from John Davis to Scott. Will salaries allow recent graduates to work for an FQHC who come out of school with high debt? Question.
Okay, that's a great question, and what the federal government has done is they've put more funds and allowed for an expansion in the National Health Service Corps. So there are now more opportunities for medical, dental, and other healthcare nursing and PA and other healthcare professionals to get reimbursement for their work for their studies to work in the FQHCs or other healthcare disparate populations. So there are more opportunities than there have been in the past number of years to help students pay off those debts. I mean, very interesting, if you look across the world, you go to Germany or Italy or Israel, and it costs about $2,000 a year to be a medical or dental student there, where our fees are, probably 100 times that. So, or sorry, 10 times that. So, that's something that we hope that once those National Health Service Corps students work in those settings, they'd want to stay there. But again, we need to make those settings attractive and create these, good preceptors and mentors, so then those young practitioners will have, reason to stay, and good mentors that will help them through the pitfalls of working with a very hard to reach and a very complicated population.
Do you know how many dental openings there are?
In Connecticut?
In the FQHCs that you showed us for dentists themselves.
On a sec.
Okay.
There's one dental director opening and one full-time dentist opening that we have posted on our job banks for the community health centers. But there are some dental suites that are just being built, and they aren't ready yet to go into operation. Once they do, then there'll be a number of dental needs for those new dental suites that are being constructed.
Okay. I'm not sure if we have another question from Kristen, so I'm going to unmute her. Kristen, did you have another question? Nope, I guess not. Her hand is just still up.
No, I don't have another question.
Okay, I think we're good then. I think we've answered everyone's questions. Thank you all very much.
Ellen?
Sure.
Hey, Ellen, this is Scott. I just had a question for Matt, and what his thought is with the potential for a medical school at Quinnipiac University and how that will impact our workforce.
Well, and I was actually quoted in the paper, so I have to be consistent with what I was quoted in the paper. Actually, we are cautiously optimistic about a new medical school. It depends upon how it's going to be structured. We understand it's going to be looking primarily at primary care, which of course is needed throughout the country, but we would hope that it would actually focus more on Connecticut-based care needs. And many Connecticut care-based needs are not that we just need primary care physicians or specialists, but we need them in certain locations for certain populations. And if Quinnipiac is looking at those questions or answers to those questions of geography and demographics, as well as simply just someone who's going to be a pediatrician or a internist, we're very excited. If it's simply to have more physicians nationally, that's a good thing for physicians nationally, but may not be the best thing for Connecticut patients.
This is David. Part of the problem is that, well, this isn't just a Connecticut issue. This is a national issue.
Right.
I mean, there are there are enough docs, but at least presently, but they aren't in the right places or the right specialties. And I think that medical schools here have the same problem that medical schools elsewhere in the country have, with sort of producing docs who are going to pursue the specialties in the places where they're most needed. And I don't know if anybody yet has come up with the right recipe to address that.
This is Matt.
Yep.
Can I answer that?
Yep.
I think that you're absolutely right that it is based upon not the type of specialty that they're going into and the geographic location. Many of them are unfortunately making decisions to go in. Well, they're fortunately making decisions to go into medicine because they care and they want to help, but because of their high debt leaving school and in many cases liability issues, are making decisions that are more financial in nature when they decide to finally practice. One of the things that we have pushed for in Connecticut are loan forgiveness or forbearance programs that would incentivize medical students and residents medical students to either stay here or come back here, and residents to stay here, because one of the things that's important that has been studied is that once a physician, after residency, is someplace 3 to 5 years, they tend to stay unless there's a dramatic reason for departure, and that is because they start a family. So if we can keep physicians in Connecticut initially, we can keep them. We can keep them in certain specialties, we can keep them. We need to have these types of incentive programs for geographic locations within Connecticut that don't have certain physicians, certain kinds of physicians by specialty. We can kind of mirror what Massachusetts has done in some way by offering incentive plans for people to either go into primary care or go into primary care in geographic locations. Connecticut actually does have some slots for and some waivers or incentive programs tied to some federal programs. The problem is there's not that many of them, and the way that they're structured creates problems. We know that there are physicians here in very urban areas in need of primary care physicians who had to leave simply because another physician moved to the area who was providing similar care, so then they had to go to places like Kansas in order to maintain that loan waiver that they were under the burden of. And we want to make sure that we structure these types of incentive programs to keep physicians there, and just because someone else comes into the area, we don't force them to then leave. But there are models out there. In addition, in Minnesota, through the University of Minnesota Duluth, they started a pilot program a few years ago that my understanding has been very successful, where they focus on primary care and actually place the medical students into primary care rural settings, community settings, where many of those medical students go back to as residents and physicians. We can look to something to that kind of model as well in Connecticut.
Mm-hmm.
David has a question for Scott. How are you recruiting students for the search program?
Okay, great question. We actually we have a website that's going to go live this end of this week. That's going to be linked with all of our academic partners. So currently, we're working with University of Connecticut School of Medicine, Dentistry, Nursing, Quinnipiac School for Physician Assistants, Fairfield University School of Nursing, Yale School of Nursing, and recruiting their students. And Rashad and I are meeting with students and talking to groups to recruit them to the program. We actually also are getting requests from students all around the country who are interested. That really wasn't, when we created this program, our thought was to focus on Connecticut students and Connecticut schools, but we're getting calls and emails from students all around the country that want to participate and come to Connecticut for a 6-week summer experience. And we'll have to weigh that with the needs of our Connecticut students. But that's a great question.
Are you recruiting more junior students or more senior students? The reason for asking is that, I can only speak from sort of the medical school venue, but a lot of students do come in with the desire to provide care to underserved populations, but by the time they get to and through their clinical rotations, that desire has waned to some extent. And so my question is, are you focusing on fairly junior students or focusing more on senior students?
In some ways, it really depends on the program that the student is in. For example, at the University of Connecticut School of Medicine, between their first year and their second year, they do have about 6 weeks that is open. So we're really targeting those students. At Quinnipiac School for Physician Assistants, they actually have a clinical externship program that's formal, and it's in it falls within their program. So we'll be working with those students as it aligns with their curriculum. So dental students I know at University of Connecticut have again a 6-week window between their first and second year. So again, we'll be attracting and recruiting those students. But let's say for University School of Nursing, their APRN, Advanced Practice Nurse students most of them are working as nurses currently and going to school at night. So we're going to have to be real creative in how we work with those students to attract them to this program.
We have a couple of more messages that I just want to share with everyone. Marcia is sending a message to Scott Many nurses in the programs that you mentioned are not going to practice in Connecticut. And from Matt, wants to let us all know that it was just announced today that Kentucky medical students get extra training in rural health. The University of Kentucky first-year medical students in the rural physician leadership track split their school time to get more experience in rural health care. Students in the program spend their first 2 years of medical school at the university and then move to Morehead State University for 2 years before potentially going into a rural practice. And I think actually we're pretty much on time to finish now. So I want to thank everybody. It's been a great conversation. This was fun. And thank you for bearing with me on learning my system here. And our next webinar is set for February 22nd, and I hope you'll all join us. And this video will be online on our website within the next couple of days, and the slides should be up very soon. Thank you.
Thank you, Ellen.
Thank you, Ellen, and thank you, everyone.
Thank you.
Thanks.
Bye-bye.
Bye. Thank you.
Bye-bye.